And we'll continue now with a talk by Dr. Elizabeth Nielson. Elizabeth is a psychologist and therapist on the trials of psilocybin-assisted treatment of alcoholic use disorder and of MDMA-assisted treatment of PTSD at New York School of Medicine. Dr. Nielson's research includes qualitative studies of patient experiences in psychedelic-assisted psychotherapy and interview studies of psychedelic therapists. So here we have an expert from the clinical side of things, the application of psychedelics in clinical studies, and Elizabeth will speak about the importance of integration work. Please give Elizabeth a warm welcome.
Thank you. Okay. So I've met a lot of you in the room and many not yet, but I just want to thank everybody for coming. It's wonderful to be here, and it really feels much more like a family reunion than a conference. So thank you for that. So as noted, I'm a psychologist with a background in addiction psychology and psychedelic-assisted therapy. I've been working with the team at NYU for a few years now as a therapist on the Hefter-funded trial of psilocybin-assisted treatment for alcohol use disorder that you heard a little bit about from Jeff Gus yesterday. And I've also recently started work on the MAPS-funded trial of MDMA-assisted treatment for post-traumatic stress disorder that you've heard about from other presenters here. It's a wonderful site, the NYU site, and I'm really grateful for all of the support and experience that I've been able to have there. I also work with a program called the Psychedelic Education and Continuing Care Program in New York. It's part of the Center for Optimal Living. And the Center for Optimal Living is a harm reduction psychotherapy center. It's founded by Dr. Andrew Tatarsky. And a couple of years ago, he and another psychologist, Ingmar Gorman, and Catherine McLean, whose research you've also heard mentioned here, formerly of Hopkins, started the what we call the psychedelic program for short. Long title would be the Psychedelic Education and Continuing Care Program, but that's kind of a mouthful. The goal of the program is to provide both education for clinicians about psychedelics and psychedelic research, as well as clinical services for people who use psychedelics in a variety of settings, or people who are thinking about using them and would like a place where they can come in, they can talk to a clinician, they can express their concerns, and they can engage in some decision-making around that process. So this work is very naturally an extension of the Center for Optimal Living's harm reduction approach. And this is the work that I'm going to be talking about today. I'm not going to be talking about my work in the clinical trials, although there's a very strong relationship there. What we do at the Center for Optimal Living is highly informed by our experience in the clinical trials, and we couldn't do it without that experience, I think. But we're also working in a different setting, in a private practice setting, providing healthcare services to the community at the psychedelic program, which is very different from working in the clinical trials. So I want to just also say this talk is based on a manuscript that I've co-authored with Ingmar Gorman. He and I work very closely together in that program. I've been working with him there for just over a year. Catherine McLean has since stepped down, but a lot of what I'm going to be discussing here is sort of co-formed with him in discussions and trainings that we've taught before. So I hope that I can do it justice by myself. I feel a little lonely up here without him, but so by way of explanation, you might have noticed that there are actually 2 more words in my title here than there are in the program. And I didn't just do that to see if you're paying attention, but I'm actually not super organized, and I just prepared this talk in the last couple of days. Although it pulls from material that we've been formulating and writing about for a while, and the manuscript that Ingmar and I are working with, it actually came together in the last week, and it was duly influenced by my attendance at Horizons conference in New York City last weekend. It was only last weekend, I can't believe it. And some of the conversations that I've had over the last week or so with people who are more familiar with the state of both addiction treatment and psychedelic research here in Stockholm. And so, as Alicia pointed out in her keynote, and as I'm hearing from other people in the community as I kind of get more familiar with things here, it seems that things are really more in the forming stage of a field of psychedelic research and psychedelic therapy in this community. And so I wanted to speak to that a little bit more and include a little bit more of our background in harm reduction, because that's really the ground that we're building this program out of. So I hope that this is adequately tailored and appropriate, and I am just hoping to respond to the needs of this particular setting. So now I've got this long title with a lot of big words, and let's go back a second. We're gonna kind of go through and break these down, talk about each component, and then see how they fit back together, and talk a little bit about the services and program that we engage in. Okay, everybody with me? Yes, great. Okay. First, I want to ask, how many people in this audience provide some kind of clinical services outside of a research setting? Like, you're a therapist, you're a psychiatrist, okay, great. And added to that, how many people are like in training in medical school, gonna be a therapist, hope to be a therapist, wanna be a therapist? All right, awesome. That's fantastic. So this talk is really for you, and it's about work outside of the research setting, although, as I said, very much informed about it. As you've already heard several presenters say, we at the program and myself individually get a lot of queries and questions from people that say things like, they've read Michael Pollan's book and they're looking for an experienced guide. Or they have read about microdosing and they really want to try it. They think it's going to be the thing that really solves their 30 years of depression that they've been struggling with. So Ingmar has very poignantly said that responding to the calls from those suffering and requesting psychedelic-assisted therapy or something along those lines in the clinical trials or elsewhere is like trying to thread a tsunami through a pinhole. It is with the greatest sense of compassion and understanding that we wish to respond to these kinds of queries, and this talk is really about how we're attempting to do that. And that's especially, I think, important at this really delicate time when we're seeing all of this wonderful new research about psychedelic-assisted therapy with psilocybin and MDMA, but it's not available yet outside of the clinical trials. And just to give you an point of reference, we have 2 sites for the MDMA work in New York City. One of those sites is what we call the private practice site that Ingmar is co-clinical investigator of. And we have, he just said at Horizons last week that they've got over 1,000 emails of people seeking to be part of those trials, and there might be about 20 spaces in that particular site. So it really is quite a narrow group that we're looking for, and a huge need and huge interest, right? So we're looking at our response to this and how we can respond to it and how we can improve that response. But let's take a second, and Dave Nichols this morning talked about a paradigm shift in psychiatry. I want to present the idea of harm reduction as a paradigm shift in addiction treatment. Some of you may be familiar with this already, but harm reduction is a movement in addiction treatment that's about moving away from a culture of stigma and imposed prescriptive goals, usually abstinence-only goals, to a culture of compassion and acceptance and respect for people who use drugs. It's a recognition of the individual's autonomy and their right to be respected and cared for, and to self-determination. Alan Marlatt, who's a psychologist who passed away a few years ago, one of the psychologists who developed the approach, he called harm reduction compassionate pragmatism, which is a way of meeting people with acceptance and providing care without requiring them to sign on to a predetermined goal. This might sound a little bit familiar to psychedelic-assisted therapy. Yeah, there's some overlapping ideas there. So harm reduction, it's egalitarian, it's empowering, it values individual choice and responsibility. It's shifting from an abstinence-only drug treatment model as the only acceptable goal to looking for any reduction in drug-related harm. It can include things like medical services, syringe exchanges, safe injection facilities, peer or professional counseling, drug testing kits to determine if one's drugs are pure or tainted with something that could be very dangerous, overdose prevention, as well as psychotherapy. So psychotherapy is one piece of the harm reduction puzzle. And it's really, I think one of the key phrases is it's about meeting people where they're at and working with them in that space to empower them to make the best decisions for themselves without predetermining what those decisions are. So for instance, if we had somebody at the center who was a drinker, who was a regular drinker, who would drink 4, 5, 6 drinks in a typical evening and then get in their car and drive home, a harm reduction goal might be to help work with them on how to find safe transportation so they're no longer risking their life, the safety of others, their legal status as a licensed driver, those kinds of things, right? So at the Center for Optimal Living, we work with a core treatment approach called Integrative Harm Reduction Psychotherapy, IHRP for short. IHRP is a framework for providing harm reduction in a psychotherapy setting. So here I'm presenting what we call the 7 therapeutic tasks of IHRP. These core tasks are things that we engage in when someone comes to the Center for Optimal Living seeking psychotherapy, and these are elaborated by Andrew Tatarski in his book, Harm Reduction, Integrative Harm Reduction Psychotherapy. It's a classic that kind of brings these together and gives some wonderful case examples about how they play out to help people. So these are the core tasks that we would engage use to engage with anyone who comes to us seeking help with something like risky cocaine use or alcohol problems or any other addictive or problematic behavior that they're looking for help with. If you're familiar with a traditional abstinence-based treatment, you'll see this is quite different. There's a focus on therapeutic alliance, ongoing assessment, personalized planning, and helping the client set their own goals for themselves. Right? So, and although many people conceptualize the experience of psychedelic use as very differently from the use of other classes of drugs, this is the ground in which our psychedelic harm reduction and integration therapy services are very firmly planted in. So let's talk for a moment about the broad field of psychedelic harm reduction. I'm jumping out of the IHRP and psychotherapy frame for a second. Psychedelic harm reduction could include any action or service that helps reduce harms related to psychedelic use in any setting, really. It can include education, helping people prepare for psychedelic use at events or in ceremony or things like that, providing resources, safety planning. It can include things like understanding, helping people understand potential mechanisms of action, how long a particular psychedelic may last so that they can adequately plan, those kinds of things. It can, during a psychedelic experience, it can help people stay safe if they're disoriented or in distress. It can help people move through difficult experiences without becoming further traumatized by them and stuck in them. And it can minimize related harms, such as being, involved with the legal system while during a psychedelic experience that's become difficult. Organizations like Dance Safe and the Zendo Project have done wonders for providing education and support to those in need, especially at festivals, on the ground at festivals. And websites like Arrowwood provide information and first-person accounts of psychedelic experiences for people to learn from. If you're not familiar with these organizations, this is just a tiny sample of the world of psychedelic harm reduction that's out there. It's not meant to be comprehensive by any means, but here are a few places to dip your toes in if you're interested. There are other organizations like the Women's Visionary Congress and psychedelic societies across the world that provide community and connection and support for people. The world of psychedelic harm reduction is full of examples of compassionate harm-reducing efforts that have grown out of years of personal experiences, participation in the community. It has a very homegrown, grassroots, and loving, community-based feel to it. So what do we mean by psychedelic integration? What is psychedelic integration in the broad sense? When I think of psychedelic integration, I think about moving from an acute experience to the long-term life implications. And in the non-clinical world, there are a variety of ways to engage in psychedelic integration, like journaling, spending time in nature, stargazing, engaging in yoga or meditation practices, maybe going on a holotropic breathwork retreat, connecting with a peer group and just discussing experiences. In the clinical trials of MDMA and psilocybin that I work with, we refer to therapy sessions that take place after a medication session as integration sessions. They're labeled as such, but integration is what takes place in the broader context of the participant's life. It's not just something that happens in a 90-minute session after an MDMA or psilocybin experience. It's something that unfolds over a longer period of time, maybe weeks, months, potentially years. People may feel that they're still integrating those experiences and insights. So you may be adjusting, for instance, in the MDMA trial, adjusting to not having the symptoms of PTSD anymore and applying the insights to a new way, an entirely new way of living. And just as I mentioned, many avenues of providing harm reduction services in general, and psychotherapy is just one, there are many avenues of providing psychedelic harm reduction, and psychotherapy is just one. Likewise, there's a variety of ways to engage in psychedelic integration, and psychotherapy is an important addition, we think, to that family of integration practices. Therapists could be involved at any stage, in the first few days or after, to help with the long-term settling in, the long-term unfolding of the experience. But before I get a little too far into that, let's position and talk about psychotherapy for a moment. So what is it? Where is it? How does it fit into this puzzle, right? Psychotherapy is a relatively modern phenomena. Most of us are probably familiar with it, either having provided it, as many of you are, or are doing or hope to do in some form, or having experienced it ourselves at some point in our lives as a patient in psychotherapy, in personal therapy. It usually takes place in the office of a licensed mental health professional. It's boundaried by time and space in certain designated sessions with somebody who's trained and authorized and licensed to provide it. Psychotherapy comes in many forms, but it really centers around the premise of talking with someone to help alleviate stress and mental suffering, reduce or treat symptoms of mental illness, change problematic or harmful behaviors such as addictions, or help people through difficult times over their lifespan of development in cases like bereavement and things like that, maybe even adjustment to having a change in the family constellation. Psychotherapy implies a special container or frame. The therapist and patient have a unique and protected relationship that's dedicated to the patient's healing. Confidentiality is assured to a large extent by legal protections, and services can even be covered by health insurance companies or an employer or a public health or government system, right? Various types of therapy are considered evidence-based mental health care, and as such have earned a really respected place in the repertoire of healthcare services available today. So although it's still stigmatized in some ways, I think that psychotherapy is generally a pretty accessible and widely available kind of service in the developed world. So if we're going to talk about why we might talk about psychedelics in psychotherapy, we could also discuss how psychotherapy itself relates to psychedelic experiences. Psychedelics are, after all, acknowledged as tools for exploring the mind and one's own inner world of experiences, and be those experiences interpersonal or cognitive or perceptual or spiritual. And psychotherapy really shifts the focus of one's inner experience in such a way that exploration and insight and change can occur. So with acknowledgement to the obvious and very large differences, I would suggest that both offer ways of changing our relationship to ourselves and the world around us, and both offer a sort of an opportunity to shift gears mentally and emotionally, to see the forest through the trees, such that we can sort of navigate our inner landscape in a different way, with a renewed sense of direction and autonomy, and hopefully live more at ease. First, we should distinguish before I get any further, psychedelic harm reduction, integration, psychotherapy from psychedelic assisted therapy, because they are related, but they are definitely not the same, right? So these are two things that I do within the same week, often sometimes within the same day. They have a great relationship, but they're really very distinct and not the same thing. There's overlap, but when I refer to psychedelic assisted therapy, I'm referring to the therapy plus psychedelic drug administration treatment models that are demonstrated in clinical trials, such as those for psilocybin and MDMA. There's a specific targeted diagnosis, a set number of sessions, a predetermined medication administration regime, and psychedelic assisted therapy includes psychedelics, whereas psychedelic harm reduction and integration work works with those experiences if and when they are had elsewhere, right? And they may never actually be had. It may just be a decision-making process that results in something entirely different that is not, doesn't include a psychedelic. So this is my wordiest slide. Put all the words in the presentation in one slide, so get it over with. In the harm reduction and integration work that we do privately, we do not provide any psychedelics. We are not present for psychedelic sessions. We do not offer referrals or guiding of sessions. We are supporting our patients in making autonomous decisions. We're reducing the harm of stigma and isolation. We're respecting the potential value of psychedelic experiences while recognizing and helping people engage in discussion about the potential risks that they may carry, depending on what their plan is or what their plans are. In psychedelic-assisted therapy, we're there with the participant through the whole session. We're preparing. We're there to assist at the time, and we have a brief duration of psychotherapy, a set number of sessions. So these two things look pretty different, right? All right. Psychedelic harm reduction can include things like assessment, education, helping with decisional balance, whereas the integration piece can focus on how experiences of psychedelics and often other alternative states of consciousness that people are experiencing in other ways are brought about and can translate into meaningful change in one's life. So this is a part where I'm going to guess that somebody in the room is thinking like, gee, it would be nice if she would give an example. Anybody? Okay, great. So I'm going to give an example that's like a conglomeration of, like typical kinds of things that people say when they write to or call the psychedelic program. So let's say, for a moment, a prospective client calls the center, often just writes an email to Ingmar or I. She's saying that she's had a life-changing experience on a recent ayahuasca retreat. She's been in Peru. She's been there for 10 days. It was amazing. She feels motivated and inspired. She feels renewed energy and determination in a very broad way across her life. She claims that she's had mild depression for 40 years. That was never adequately treated, never could really resolve, and it has just vanished. And she's feeling ready to roll up her sleeves and engage in some very challenging work as an environmentalist that she's been dreaming about since childhood. She feels that her experience was valuable, it was authentic, and it was incredibly healing. She's calling because she's back in New York and she's had to go back to work and she just doesn't feel that she fits in anymore. She spoke about her experience in an integration circle and she's talked with friends and family and long-term therapists since her return. But she's sitting at her computer or desk all day looking kind of like this. And she's really in a bit of distress. She's not feeling understood. She's calling because she's afraid that her great inspiration and healing experience is very quickly turning into a sense of alienation and rejection, and that she's likely to become even more depressed if she can't find a way to live now that is aligned with her values and the things that she uncovered in this session. So I present this again as a typical scenario because this is precisely where I think that integration psychotherapy comes in. Integration is about how those experiences unfold in the larger picture of one's life, and the amazing insights and inspirations that people have may actually turn into quite a distressing situation if they're met with misunderstanding and rejection or dismissal at home, or by a psychotherapist, perhaps a psychotherapist that this person had seen before or goes back to or calls looking for help. So just as someone who's had a problem with alcohol use may need to rearrange their entire social life, their entire way of living to accommodate sobriety, the insights of such an experience may leave someone feeling like a stranger in a once familiar world. What was once comforting may now be distressing. What was once taken for granted may now be questioned. And what was once considered rewarding may have lost its value. And these are the kinds of things that that therapy can actually really help with. Sometimes I think of integration in psychotherapy as psychedelic integration in therapy as post-psychedelic experience adjustment therapy. So it's really about adjusting to being one's self in what was a world constructed in one way and may need to be kind of reconstructed to accommodate a different way of living, hopefully a happier one. Whoops, come on. So adjusting to and integrating experiences doesn't always happen with a therapist, nor would we insist that it always needs to. The establishment of a clinical program that offers psychedelic harm reduction and integration does not imply that everyone who uses psychedelics needs a clinician. We certainly see that many people go through this process with peer support, other methods, other avenues of integration, and do just fine. Many people will turn to existing practices, yoga, journaling, things they've done before, time in nature, or maybe seek a peer group or spiritual leader or something like that. So who would come to therapy for integration? Who would really need or want to take advantage of the option to address this kind of thing in therapy? Many of the people we see have an existing diagnosis of depression, addictive disorder, or other distresses, other types of suffering. As clinicians, we're in a really unique position to understand the other treatments they've engaged in and tried, and to integrate what may have worked for them in the past, or pieces of those that may work for them now. There may be other life stressors or conditions that are unchanged or even exacerbated by psychedelic experiences, and some people may not have the resources or comfort level to seek a community or peer group, and they may prefer the safety and familiarity of a psychotherapist's office. Being able to access support for integration in a licensed therapist's office lends a legitimacy and sets precedent for the potential value of these experiences. People sometimes report that they find it very validating to be able to come in and actually talk about this in a therapy setting. So just by doing that, just by showing up and us providing that and them being there to engage in it, we're actually kind of dealing an additional blow to the stigma with which people may have been met elsewhere. Psychedelic integration and psychotherapy is one of a range of options. It's appropriate for some, but not all people who choose to use psychedelics in a variety in any setting. So we are attempting to respond with compassion to these calls, these needs, these requests for help. How do we do this in practice? What do we actually offer? Well, we offer individual consultations, which can take place at any point during a person's decision to use or not use psychedelics. Sometimes they occur before an experience, and sometimes people call us afterward. I kind of prefer if people call us before, because we get a little bit of a sense of what's going on for them before, but it happens either way. They're tailored to the unique needs of each person and offered as a standalone service. We think this is really important because we don't require somebody to commit to therapy or a course of treatment, but we actually open the door to that if someone wants it. There's no predetermined goal. There's no long-term commitment that people have to sign up for. And this is really consistent with our harm reduction approach, right? Meeting people where they're at. If they just want to come in for one consultation meeting, okay. And because we don't offer psychedelic assisted therapy or make any kind of referral for underground services or retreats abroad or anything like that, we're really in a place of offering as much of a fair and balanced and non-judgmental safe space for making decisions as possible. We also offer both brief and longer-term psychotherapy. Sometimes people have a great therapist that they've been working with for years, but they really feel they need some specialized sessions around this particular topic. Sometimes people don't want to be in longer-term psychotherapy. They feel like it's just not for them at this point in their lives, and so we help people with other methods. Sometimes they want a few sessions while they're getting established in other practices. So we're really open to meeting people where they're at, giving something very individualized. Sometimes people are a good fit for longer-term psychotherapy with someone at the center, either myself or Ingmar or somebody who works in close consultation with us, one of the other therapists, and we provide that as well. And I also run a weekly psychotherapy group. It's called the Psychedelic Harm Reduction and Exploration Group, and this is a group, a psychotherapy group that combines a classic interpersonal process group with the principles of psychedelic harm reduction and integration that I've started to outline here. I've written about it elsewhere on Chakruna, so if you're interested, please check that out. That's been running about 10 months now, and it's really going strong, and we are hoping to support other clinicians in the community to start similar services. Well, what did I mean by this piece of the title? Do no harm by omission. Well, okay, you probably recognize the phrase "do no harm," right? That's one of the first principles that we sign on and engage with in order to ensure that we're not harming people with our practices and taking an ethical responsibility for their care. As harm reduction therapists, we recognize that stigma and isolation can actually be very harmful. I've said elsewhere that psychedelic-assisted therapy involves using a stigmatized set of compounds to treat a stigmatized set of disorders, and even the most of us who have set out to do this work in the most respected institutions have likely experienced some kind of stigma because of it, right? Some funny looks or being told, why are you studying that? Or some questioning, things like that. Maybe a little bit less so now in the United States, but it's only very recently. Many of us in this field at least have each other. We have our training and our experiences to garner support from. We have beautiful gatherings and conferences such as this, which are really, really essential to breaking that stigma and isolation professionally. But some of the people who call us are not so fortunate to have such a network of support. And I believe that stigma and isolation can take place in the therapy office too, when patients are either seeking to bring in psychedelic experiences they find meaningful and helpful and are met with misunderstanding, lack of curiosity, or outright dismissal by their therapist, psychiatrist, or other healthcare provider. Patients may be discouraged from discussing such experiences. They may be discouraged from asking questions and asking for the kinds of information that they would need to help keep themselves safer than they otherwise could be. And in this case, they may fail to integrate these experiences, or worse, feel further isolation and stigma for having had them, actually feel that, there's something wrong with me for having had this, or, I have somehow done something I shouldn't have done. There can be guilt, there can be shame, a lot of things around that, when those experiences are not met with understanding. And this isn't to blame psychotherapists. Practically none of us were trained to talk about these kinds of experiences, psychedelic experiences, spiritual experiences, or anything like that in our graduate programs. And even today, there are very few resources for those who are working outside of the trials to get education and training in this. conferences like this being a really unique opportunity. But I do believe that the interest in these compounds is growing, and that with that, the number of curious people out there seeking them and trying them and wanting to discuss them with their therapists is too. So just as harm reduction psychotherapy reduces drug-related harm by inviting these topics in and exploring them in the safe, supportive atmosphere, I think that psychedelic harm reduction and integration can take place in psychotherapy, thereby reducing the harms of stigma and isolation and missed opportunities for growth. I have just a few minutes left. I want to go over just a couple of important points that I would emphasize with some of the people that I'm working with and training, and then I'll close up and we'll have time for questions, okay? So just a couple final points that I emphasize, especially when I'm talking with people that are coming to the program and looking for a consultation or maybe in a consultation, things like that. First, important to emphasize, psychedelic-assisted therapy is not available outside of research settings. It cannot be reproduced in other settings. The kinds of outcomes and data that we're seeing, we can't count on having those in other settings. And there's a relationship, sure, but they shouldn't be taken as generalizable. Psychedelics are not a magic bullet. They often stir things up in a way that distress increases in the short term and may offer opportunity for growth within that space. But it's important for, I think, clinicians and people who decide to try psychedelics in other settings to understand this process and to be aware of what they're looking at without pathologizing it further, without increasing stress and worry in somebody who may have had an experience and be showing up a little bit raw, a little bit emotional, right? So being able to understand that as part of the unfolding. A final point is that not everybody will be able to take psychedelics if and when they do become legally available as medicines, right? There are still going to be some health rule-outs. There are still going to be some people that aren't good candidates. And there are still going to be people for whom it's just not something that they're comfortable with. And there are alternatives, and I think we really need to make sure that we present those and that we help people be aware of them such that they don't feel that psychedelics are the only option, the only avenue for healing. It can be really easy to fall into that way of thinking about them, which then puts a lot of pressure on people to get it right and have that experience that's going to be the be-all, end-all thing. The experience is never going to be the way people imagine it precisely, and putting all of their eggs in that basket can actually add to the sort of stress that may actually be very counterproductive. So I really like to work with people to encourage them to develop a meditation practice, go on a breathwork retreat, maybe do some float tank sessions or something like that, so that they have other ways of accessing insights and alternative states of consciousness and aren't completely reliant on the psychedelic experience for that. And explore not just what they're seeking out of a psychedelic experience, but what are they really seeking in other ways that they may find it? What kinds of insights and what kinds of healing? And where are some other ways they might find it? So I want to say thanks to Andrew and Ingmar and Jennifer Talley, the wonderful crew at the Center for Optimal Living, everybody on the team who are so supportive and interested and enthusiastic about this work, and helping me be here by covering some of my responsibilities at home so I can travel. The NYU Experimental Therapeutics Research Lab, it's the long form title for the team there, half of which is here in this room, which is great, and the Effective Care Team in New York City, which is the private practice MDMA-assisted therapy research site, the organizers of this conference for making this wonderful family reunion in Stockholm, thank you. My clients, participants, and group members whose contributions and patience and willingness, people who have, study participants are volunteering their time and allowing us to really work with them in a way that's very experimental and new and taking on that risk. So a warm thanks to them, the people that have really engaged in this, in seeking this treatment, and are showing up for it and working with us. It's very much something that we're co-creating, because this is we're still forming ways of doing this, and everyone else who has supported us in being here, making us safe, making sure that the lights are on and the food is served and there's coffee, and all of that goes into it. If you're interested and you want to see more about our program, that's the website, and also where to find me, my contact information. We've gotten some feedback that the website helps people understand how we present this kind of work to the public. So if you're thinking of doing it and you'd like a prototype or some examples of how we word things, that's the place to go. So I'll end there. Thank you so much, and I really want to hear your questions.
Thank you very much, Elizabeth, for this very valuable talk you gave us. You pointed out some very important things there. And we are fortunate to have some 5 minutes for a couple of questions. If you have any, please come to this table and take the mic.
Does it happen that you get emergency calls? For example, I took something and now, what do you do then?
That's a very important point. Thank you for bringing that up. So, backtracking from that for a second, when we start to work with people, one of the things that we often wind up touching on is sometimes people will ask, well, can I take psychedelics and come in? Like, can I take my own and come in and have therapy in your office? And the answer is no. And we try to make that very clear that we're not a facility, we're a private psychotherapy office. We're not a place that can respond to that. Nor would we think that would be ethical or helpful or something that we could work with. We can't consent people for that kind of therapy, and we definitely make that clear in our initial conversations with people. We haven't actually had calls that I've interacted with, and there may have been some in the history of the program before I got there, but I haven't actually had calls from people that are actively in the middle of a psychedelic experience and calling for an emergency. And if you check out our materials, I think it kind of makes it clear that we're a psychotherapy office, a place to come and talk about these experiences. That being said, if someone did show up, depending on who's at the office at the time, I would hope that they would, I know that they would at least have a safe place to sit and ride things out, and emergency care would be called for them if needed. But we certainly couldn't really engage someone in psychedelic therapy in that setting. It just wouldn't be possible. So we try to make that clear ahead of time. Yeah. Thank you.
Hello, thanks. Do you have recommendations for research papers on the topic of integration?
On the topic, research papers to read? Well, the one that we're working on, hopefully will be out at some point. The papers that are the first thing that come to mind are the ones that have been written about the psychotherapy model in the clinical trials. There's one that I put out earlier this year that's about the debriefing sessions and in the alcohol use disorder trial that looks at what people are saying, how they're saying it, and really tries to tie people's statements into the underlying constructs and motivators for change in that session. But there hasn't been a whole lot written about it. There probably are a few more that I'm not thinking of off the top of my head, but there hasn't been a whole lot written about it. I think it's a great place to do some writing and some exploration.
Yeah, one of the most under-researched areas of psychedelic therapy, definitely, or psychedelics in general.
Yeah.
Yeah, thanks.
Sure. Can you come over to the mic? Thank you. Or you can pass it. Thank you.
Thank you for your talk. How did the case that you described ended? She came to you. What kind of advice did you give?
Well, that was not a one specific case. It was just sort of like a typical example of what we often see. But you know, in a case like that, what we would probably do is have somebody come in and do an assessment visit, an initial evaluation. We would probably talk about things like what the intentions were and what the outcome is, what kinds of sources of support and resources this person might have, whether or not they had an existing practice of, you know, any kind of meditative practice, yoga practice, something like that, that they could use and draw on to help with this situation, to help do some brainstorming around resources, maybe do some what I call normalizing, so helping people understand that this is a natural part of the process. This doesn't mean, you know, as long as you're safe and able to take care of yourself, this is something that can naturally unfold over time. The way you're feeling right now is may be an important actual part of the process, as opposed to something to pathologize and something to be afraid of and something to run out and change right away. And we would probably, you know, try to engage in at least a few follow-up sessions, brief therapy. We might talk to that person about having longer-term therapy with somebody who is familiar with this kind of process. We may provide that ourselves. We may refer that person somewhere else, depending on what their resources are, what their needs are, whether or not they even live locally and can access us. They might be able to participate in the group to see how others are getting through similar processes and things like that. Yeah. And we would be assessing, you know, kind of continually assessing what the needs are. Are they really falling back into a depression that warrants further or other kinds of treatment and referral to maybe to a psychiatrist or something like that? Or does this seem to be something that they're, you know, distressed about but able to manage and move through? Yeah, sure, thanks. Are we good?
Thanks again, Elizabeth.
Thank you.
That was our time with you. Thanks. Thank you.